Hello, everyone. Happy New Year and welcome to today's webinar, What's New in Dental Billing and Coding for 2025. My name is Gary Taratsian with the webinar team here at Rectangle Health, and we've got a fantastic presentation lined up for you today. Before we jump in, just a little bit of background on Rectangle Health. For over 30 years, we've been a partner to more than 40,000 healthcare providers who utilize our practice management bridge platform and easy to implement, easy to use software designed to automate day-to-day operations, bring about efficiency from payments to compliance and staying in touch with patients. Today's webinar ties in with our best-in-class bridge payment solution that lives within the Practice Management Bridge platform. And as we go through the training today, if you'd like to see firsthand how this tool can help you quickly and automatically capture patient payments, pre-care, point of care, and post-care, eliminate the need to send out those paper statements, and save you and your colleagues valuable time and deliver enhanced patient experiences. A link to schedule some time with our practice consultants will be in the chat just as soon as I pass the mic over to our speakers today. Just a quick few housekeeping notes here. This is a 1 hour course valid for one CE credit. We are a PACE provider for CE through AGD. You will receive your CE credits via email. Please allow for up to 2 weeks to receive those credits and make sure you check your spam and junk folders. If you're joining us on mobile, please note the experience will be much better from a desktop. You may also struggle to answer the mandatory polling questions if you're joining us on audio only or mobile. We'll have 3 polling questions total throughout the hour, and in order to receive your CE, you have to participate in these questions. At the end of the webinar, you'll be prompted to take a brief survey. Your feedback is incredibly valuable to us in delivering the best training experiences possible. If you have any questions at all today throughout the presentation, please don't hesitate to email us at webinar@rectanglehealth.com. I'll drop that email address in the chat shortly. Because this is a 1 hour CE course and we have a lot to cover, we will reply to any and all questions post-webinar via email. We will also be sending out a link to the recording of this webinar within 24 hours, so be on the lookout for that. And one more housekeeping item below the link to schedule time for a demo of the solution, bridge payments. I'll also place a link for our upcoming CE credit HIPAA training. If you haven't registered for that one, there's still time to secure your seat and learn the latest in HIPAA enforcement trends. With that, it is now my great pleasure to introduce our panel and speakers today. We're excited to welcome great friends of ours here at Rectangle Health, Stephen J. Anderson, Pam Peterson, and Desiree McCauley back to our webinar program. Our host, Stephen, is the founder of Total Patient Service Institute, co-founder of Crown Council, and the Smiles for Life Foundation. As an entrepreneur, presenter, author, philanthropist, Stephen has developed systems for success for professionals, executives, and youth alike. And as the founder of over a dozen businesses, Stephen has propelled organizations and individuals to the highest levels of performance and productivity. He has been named Businessman of the Year and is an Ernst & Young Entrepreneur of the Year finalist. I'll drop a link to Stephen's LinkedIn profile so you can all connect and chat in the chat as well. And with that, Stephen, Happy New Year. Thank you for taking time to present this session. Take it away.
Thanks, Gary. Excited about the next few minutes together. This is always a hot topic this time of the year, and our team at Total Patient Service is excited to be able to give you the update on the things you need to know right now to be able to bill and code correctly and get paid what you're earning. So with me today is Pam Peterson, who is the president of Total Patient Service, TOPS for short. Pam has had an entire career in dentistry and has interacted with literally thousands of practices all over the country. She's going to share her expertise in this area today, as well as Desiree McCauley, who is part of our virtual coaching team. And Desiree works with dental practices every day all over the country, coaching them on best practices for patient service and case acceptance. So Pam, Des, thanks for being part of the team today. And we're going to get started. Just to give you a quick heads up, we're going to go through a huge quantity of information today. New codes, discontinued codes, changed codes, things that get miscoded. You'll want to take notes. And near the end of the presentation, we do have a hack sheet, thanks to Des. where all of the critical information that we'll cover today is summarized. So you'll have a little cheat sheet, a hack sheet to be able to implement what we talked about today. So with that, Des, let's get rolling with our next slides. We have some fun interactive experiences for you today, where we're actually going to interact back and forth via an additional piece of software. So if you have your cell phone handy, if you're doing this on desktop, if you got your cell phone handy, this is just a fun additional thing you can do to interact. You can scan that QR code right now. I'm going to do it with mine. And then you're welcome to sign in and go ahead and enter. And there will be some interactive questions. And let's see, what's our pin, Des?
6729709.
Say that again, 672.
6729709.
All right, and they're saying that pin number is not recognized.
Another pen.
So,
On the back end here.
all right, let's go ahead and Des, you can work on that. Let's move the slide deck ahead and we'll get started on the content. We'll come back to that little technical issue there, and let's move ahead. So Des, if you want to share your screen, and let's move.
Okay.
As she's getting that up, we're going to start with new codes. What's new in 2025? We're going to talk about 10 new additional codes, 8 revisions, 4 changes, and 2 deletions. And Pam is going to walk us through that. So Pam, take it away.
All right, perfect. Thank you, Steve. All right, guys, before you advance, I always want to share the resource. And by the way, I want to echo the sentiments. Happy New Year. I'm excited for this every year. We love, on behalf of myself and our TOPS team, of being the code messenger. Our resource is from ADA. And so ADA has a code maintenance committee, also known as CMC, and they're responsible for reviewing all of the codes where they add, delete, and make editorial changes, just like Steve just mentioned. And so every year in March, they meet at their headquarters located in Chicago, and that's where all the magic happens. And so they have a sole purpose, which is to make sure that all of you are supported in the dental industry, that your patients are supported, and also the payers are supported, which is the insurance company. So they're the advocate for all three. So let's tap in to see what's new, what's revised, and what's been removed. All right, Des, you can advance. All right, so the first new code is D02956. This is a removal of an indirect restoration on a natural tooth. Now, most would think this is inclusive. Well, the code maintenance committee felt that this is a unique and individual procedure, so that now there's a D2956 for removal of the indirect restoration before replacing the restoration. And this is not to be used for temporary or provisional restoration. This isn't a poll question, but I do want you to count how many times I say this because I want you to remember it. Although we are receiving some amazing new codes, sometimes the insurance payers are a little bit behind. So I want to make sure that you trust but verify. On behalf of your patients, make sure that you get a breakdown of the insurance savings and add these codes that we're talking about today so that you'll know exactly what the estimated coverage will be. Next.
In other words, Pam, just because there's a code for it doesn't mean that you get paid for it by an insurance company.
Correct.
Okay.
Correct. I didn't want them to come and have a birthday party without a present. All right, so the next new code is under implant services. This is D6180. This is implant maintenance procedure. And so this is cleaning the implant, and the key word is in the patient's mouth, where it's not removed. And so this is considered a therapeutic procedure, not a preventive. So you cannot use this in conjunction with an 1110. So the 6180 is to clean the implant while it's in the patient's mouth. Next slide, Des. The next new implant service code is D6193. This is a replacement of an implant screw. So typically a band is placed and submitted around the molar, and there's 2 codes. Well, this new code 6193, it covers removing and replacing the implant screw. The next new code, this is under oral surgery. So if your practice does oral surgery, this would be important to you. It's a D7252. This is a partial extraction of an immediate implant placement. And so this is also known as a partial extraction technique or a socket shield technique. And I'll just talk about this in layman's term. So if there's a buccal or a facial root that's thin and would be at risk for fracturing during a procedure, the clinician would do a socket shield technique. And so the new code is now, they don't have to do it free. The new code is 7252. Next slide, Des. The next new code is an oral surgery code as well. It's a 7259. This is a nerve dissection, and this involves separating or isolating the nerve doing a surgical procedure. And so when I saw this come across our desk, I stopped for just a moment because I know that many clinicians, if you do oral surgery in your practice, they do this procedure and have been treating it as a part of the actual procedure. So I say this when they are protecting the nerve during the surgical procedure, make sure you share this with the doctor and the clinical assistant. So if they're doing this procedure, they know now that there's a code for it. The next new code is an orthodontics code. This is D8091. This is a comprehensive orthodontic treatment for orthodontic surgery. And so this code was introduced for patients that, because this procedure will require multiple phases. And it's long-term so that it's pre and post-operative cases. The D8070, which is you see at the bottom of the screen, and the D8080 and the D8090, those are still active codes. They have not been removed. But the one that's introduced, the 8091, is for orthodontic surgery. The next new code is ortho as well. So ortho is winning. Is D8671. This is a periodic orthodontic treatment visit. This is to evaluate the progress. Now, the key phrase for this, the utilization of this code is complex craniofacial cases. These are for patients that require surgery. The current code, D8670, is still alive and well. This is for a periodic orthodontic visit. Next. There's two new codes for adjunctive services that have been added. The first is 9913. This is the administration of neuromodulators. Now, neuromodulators, there's plenty out there, but the one that we are most familiar with, I say we because I want you to be with me, is Botox, which can be used for TMJ, muscle pain, joint pains, or removing unwanted lines in your face. The D9914 is administration of dermal fillers. So these are two new codes that were added. And always trust but verify. If this is something you do in your practice, make sure that you add it to your system when you're getting a breakdown of insurance savings on behalf of your patient. The next new code is sleep apnea services. This is a D9959. It's an unspecified sleep apnea service procedure. The Code Maintenance Committee felt that it was necessary to provide a code for dentists because there are times when there is no unique or clear treatment, and they wanted to make sure that they had an unambiguous CD code for the clinicians. Let's talk about revised. So the next code that was revised is the D0160. Now, we've talked about this code in the past, and I was excited to see the revision on this particular code. This code falls under the umbrella of exams. It's not a standalone code. It must be followed by a comprehensive exam code, which is a 150, or a comprehensive periodontal exam code, which is a D180. There are some limitations on this particular code. Most payers will pay up to twice a year, and always trust but verify. So this actual exam code is an oral evaluation after a problem focus. And so when a patient needs to come back for a second appointment, you no longer have to do a look-see or a complimentary appointment. There's a code for it, which is a D0160. And what's been added for revision is sleep-related breathing disorders. The next code that was revised is the D0801. This is an intraoral surface scan, and the code actually stayed the same. The language was removed. They removed 3D dental surface scan. They wanted to, because it placed limitations on the utilization of the code. So the new language is scanning of all structures of the oral cavity. The next code that was revised is the D1330. The code is the same. What was revised is all of the language. So the language now is oral hygiene instructions. The Code Maintenance Committee felt like that oral hygiene instructions should be personalized. And so the hygienist will personalize their information by each patient. What was removed is the D2941, is the interim therapeutic restoration, primarily dentin. And here's what it was replaced with. The D2940. So the D2940 is a placement of an interim direct restoration. And so if I were to talk about this code in layman's terms, this is when a patient has pain in a tooth and requires healing, where the doctor may want to see the patient back in about a couple of days or a week to make sure that the tooth is comfortable before moving to a final restoration. So this is not definitive treatment. 30 years ago, what I would have used, which is IRM, which is a sedative filling. And I know that there's probably some, Des is smiling. No one talks about that anymore because it's an older restoration. But this is the new code for it, 2940. And this is when definitive treatment has not been completed.
All right, we have our first poll question. So this is the have you been paying attention question, right, Gary? So we're going to launch this. How many codes were revised for this year?
Oh, I think it's a question 1. They haven't learned this one yet.
Sorry about that all.
Okay.
They'll enter it. They're smart.
All right. How many codes were deleted in 2025?
The poll question shows, what does Ohio mean?
Yeah, so we need to put the other poll question up, Gary. This is the one. How many were revised?
There we go.
Ah,
How many codes were deleted in 2025?
All right, I guess we're doing deleted.
All right.
Give it another second here. Getting some results. Give it another 2 seconds here. And
They're going to ace it.
mhm.
and the results are in. Steven?
There's a lot. We had new codes, revised codes, deleted codes. This was a little bit tricky. So there are actually 2 that were deleted. So all good.
All right, let's talk about a few more codes that were revised. So implant services, the 6011, which is a surgical access to the implant body. And so what was updated on this particular code was not the actual code, it was the language. The Code Maintenance Committee removed the portion of the language where you see at the bottom. They removed it completely. They felt that it was redundant and unnecessary language, which would limit the use of the code. So that was removed. The next code that was revised is the D6080. This is an implant maintenance procedure with a full arch hybrid prosthesis, which is removed and reinserted. And so earlier, when I talked about the new code, which is the D6180, this is a therapeutic procedure of cleaning the implant in the patient's mouth. This is cleaning the implant by removing it from the patient's mouth and reinserting. And so if you remove the implant and you clean and you reinsert, it's 6080. Earlier, if you clean in the patient's mouth, it is 6180. The difference, I'll do a little commentary on this. The difference is when the doctor recommends a 6180, he or she is taking a look and the patient is not at risk as far as periodontal problems around the implant. The next code that was revised is an implant service code. It's the D6180. This is scaling and debridement of a single implant. And so if a patient has bleeding upon probing and increased pocket depths, this is a code that you would use as far as cleaning of a single implant. And this is in the patient's mouth as well. This procedure is not performed in conjunction with an 1110, a 4910, or D4346. This is considered inclusive. And so you want to make sure that you trust but verify, get a breakdown of your patient's insurance savings prior to this code. Next, Des. The code that was removed, deleted, is D6095. This is a repair implant abutment by report. And what it was replaced with is the D6090. So this is repair of the implant abutment supported prostheses. They also removed the language. They felt that the language was redundant and unnecessary. And with that being said, the Code Maintenance Committee said this several times whenever they remove language, it limits the utilization of the code.
And we're going to skip that one, Gary, so we'll move on. We already did that one.
Okay. All right, let's jump into new claim form updates. If you were with us last year, we talked about this last year. It was over 5 years since ADA has updated an insurance claim, and it's been updated. So Des, kind of advance so we can take a look. When you look at the very bottom left corner, it should say 2024. The old claim says 2019. And if you chose to continue to use the 2019 claim last year and you still were able to get your claims processed, that's because you were given a break. They had a 9-month buffer that they didn't share with us, and the 9-month buffer is gone. And so please make sure that you use the new code, which is 2024. If you haven't already, put it in place so that you're using the right claim, because the goal is to submit a clean claim so that you can get paid within 7 to 14 days. Next claim, Des. All right, so let's talk about some key areas that are important. So in box 3A is exactly where you place the payer ID for primary dental benefits. In box 11A, if you have other coverage, which you can see in the top left corner on the box, if you have other coverage like a secondary insurance, you would place the payer ID in box 11A. Next slide. Box 28, that's where you place all of the services for the restorative procedures. Please avoid placing the services in the notes section where the narrative goes. You want to make sure that you place it in the correct box. Box 39A. So box 39A is where you enter if the patient had previous SRP, gum therapy, scaling and root planing, all the names. You want to place the estimated date in box 39A. Now, they're pretty sticklers about this. With the payers, they get an abundance of claims, so they scan it. And don't quote me on this, but I believe that they have some support with AI. So you want to make sure that you do it exactly like they ask so that you can get paid timely. So you want to put the 2-digit month, 2-digit date, and the year format so that you can get your claim processed. Next slide. Box 53A through 58. So this box has been amended. So this is where the treating dentist information goes, also known as locum tenens. And so in layman's terms, this is a specialist or a temporary dentist, a dentist that does not own the business. Whoever came in and they provided the treatment for the patient, their information goes here, not the business owner, but the treating dentist. If you decide to do it a different way and not like I just recommended by the dentist who treats, what happens, Steve?
It's insurance fraud. So the claim always has to be filed with the treating dentist's information in this area. If you're entering anything other than who actually treated the patient, that is insurance fraud.
Thank you, Steve. Everybody out there in webinar land, that's his favorite box. All right.
There's a lot of ways that you can commit insurance fraud, and that's one of them.
And we don't do that around here. They don't either. And I can't see them, but I know they're shaking their head saying, you're right, Pam. All right, box 56A is the correction, is to make sure that you place the specialty code in box 56A. And every provider has a specialty code. So you want to make sure that you place that in the correct box. Box 33, make sure that you place the missing teeth in box 33. It's important, and we added this on here because it's often where we'll see the missing teeth is in the section of box 35, which is not where it belongs. In box 35, you want to place your narrative remarks, and you have up to 80 characters for narratives. And so if you go past that, you run the risk of your claim being rejected. So up to 80 characters, and you make sure that you place your narratives in box 35. Facts, not emotions. Next slide, Des.
Can I add something there, Pam? Something that was an aha for me, but probably shouldn't have been.
Of course.
It also has to come directly from the chart notes. So your clinical notes that are in your computer should match exactly what's on that claim form. You can't make up your own, fortunately.
Box 35 is Desiree's favorite box. All right, thanks, Des. All right, so let's talk about what's next. There are a couple of codes that if not coded properly or used properly, they can get us in some trouble. Let's talk about them, Des. All right, the first is why alternating a D4910 and a D1110 is never a good plan. We recommend, and we're supported by our good friends at Practice Booster, is code what you do and do what you code. If your patient has gum disease and they're coming in for a perio maintenance D4910, that's what we recommend that you code. And learn this from the late Dr. Charles Blair, is in the notes section, just write, please pay the allowable benefits towards the procedure. That way your practice is following your standard of care and not wavering. So code what
Say that again, Pam. Give him that verbiage again.
So in the narrative box, you want to list, to write it out, pay the allowable amount towards the procedure. By doing that, it'll put you in a position where you are adhering to your practice standard of care and you're not wavering. So if it's a 49,
yeah, one of the things we hear a lot is, well, we don't code it that way because the insurance isn't going to pay for it. So the rule is code what you do and do what you code. And then if you have to provide a narrative, so even if insurance isn't going to pay for 4 4910s every year, you still code it a 4910 if that's what you're doing. And then in the narrative, give them the heads up that they can pay it out as something else, but you always code it the way you do it.
The allowable amount. All right, thank you, Steve. All right, let's talk about some exam codes. So there's 3 exam codes that are frequently used codes, so you use them often, which is the D0120, D0140, D0150. The 3 codes that are not used as often are the D160, 170, and 180. So let's unpack this and see what you're doing in your practice. So the first, this is one of the codes that we talked about earlier that was revised. It's the D0160. So this will sound like I'm repeating, and I love repeating. So this is a complete exam, periodontal exam code. Like I said earlier, this is not a standalone code. It must be followed by a comprehensive exam code, which is a 150, or a periodontal exam code, which is a 180. And there are some frequency is not as rigid. There are some payers that'll pay up to twice a year. Always trust but verify and get a breakdown of your insurance savings. So in the past, before this was revised, this is a second appointment when a doctor needs to do a workup, have some diagnostic cast for a patient that has TMJ or extensive periodontal disease, and you want to bring them back. What was added now is a patient that has sleep-related breathing disorders. This is how you can use the D0160. Next slide, Des. The D0170 falls under the umbrella of an exam code as well. Involves re-evaluation of an established patient for a problem focused area where definitive treatment has not been rendered. The example that you see on the screen, if a patient has leukoplakia tissue, which is the white that you see on the tongue, when the doctor wants to bring them back to make sure that they're healing properly. Or if they have trauma or an accident, they want to bring them back to make sure that they're healing properly. And this code, I'll repeat, it's when definitive treatment has not been rendered. Now, the D170, where you see it's miscoded, most of the time it's confused with a D0171. D0171 is for is the code that you use when you bring someone back to check on for after an extraction or for suture removals. So you want to make sure that you don't get 171 confused with 170. 170 falls under the same category as the 160, what we just talked about. There are some limitations. There are some payers that will pay up to twice a year. You still have to trust but verify. And it must be followed by an exam code, which is a 150 or a 180. Speaking of 180, which is a D0180, this is a comprehensive periodontal evaluation code. This can be used for new or established patients. Now, although this is a comprehensive exam code, it's a standalone and cannot be used with a 150. And the frequency isn't as rigid with a 180 as it is a 150. The 180, there's some payers that will pay twice a year. Trust but verify. Now, when using this 180, this is for patients who present signs or symptoms for periodontal disease or have high risk factors, such as any inflammatory diseases, such as diabetes, high cholesterol, or hypertension. Now, when using this code, there are some stipulations when submitting to insurance. It must be followed with a full mouth periodontal probing, which is 6 points around every tooth. If you were to just send with the line or your spot probing, you run the risk of this code being rejected. So it must be 6 point measurement around every tooth. Also, you must chart bleeding points, gingival attachment, bone loss, and furcation. All of that must follow this code so that you can get paid within 7 days, 7 to 10 days. All right, Des. There are a few codes that are underutilized. Let's talk about them. The D0220 and the D0230. 220 is frequently used. It's for a PA. What's not frequently used is the D2030. D0230. Now, the difference is the 220 is for the first PA. The 230 is for an additional PA. If you do 220 for both PAs, the payer will reject the actual claim. So you want to make sure that you use the D0230 for an additional PA. Let's talk about buildups. The one that's frequently used is the D2950. And I know you're saying it's inclusive. I still want to make sure that I repeat this. Code what you do and bill out what you do as well. And so although there are some payers say that this is inclusive, you still want to make sure that you bill it out. So D2950 buildup is for retention. The D2949 is for a non-vital tooth. So if a tooth has been treated with endo, this is a code that you would use to restore it, which is 2949. So please make sure that you know the difference between the two. All right, welcome to Ohio, and I don't mean the state. We love acronyms, and so we subscribe to only handle it once. And so we're going to talk about some things that if you only handle it once so that you can get paid quickly, it will have put you in a position where you can do the things that you really enjoy doing, which is caring for your patients. All right, let's go through them, Des. The first, you want to make sure that the insurance claim is filled out properly. You can keep going, Des. The correct procedures are listed on the claim. Like Des said earlier, it should match what you have in the patient's chart. The claim is filed and submitted within 24 hours. The correct documentation is sent with the claim. Only handle it once, and then review the claim submission status, which we'll talk about in just a second.
All right, here's the poll question, Gary. You get to put this one. We gave him a sneak peek at this
Yeah,
earlier on.
absolutely. Had a head start on that one, so I will relaunch this poll.
Just checking to make sure you're still out there, everybody. So
We're gonna ace it.
What does Ohio mean?
there you go.
Fingers crossed.
And folks, while these answers are coming in, for anybody that do not worry about the previous polling question, you will still get CE. That was a hiccup on our end. Thank you. And we'll close this up in a second. Share the results.
There you go.
Good. Great.
Only handle it once.
All right. So this is about getting paid and making sure that you get paid timely. Let's talk about the 3 reports, and the keyword is daily. Insurance claims not sent. These are reports that we recommend that you check daily. Insurance claims not sent, procedures not attached to insurance, and secondary insurance claims not sent. Now, with secondary insurance claims not sent, whether you take secondary insurance or not, we recommend that you check the report. There's often user error. So you want to make sure that when you look at these reports, that at the end of the day, they're all blank so that you can submit and get paid timely. And it doesn't matter what practice management software you are using. The language may be slightly different, but every practice management software has these 3 reports for you to run. Next slide, Des. Submission status. So there's 3 steps, which is the validation, confirmation, clearinghouse. The goal is to get to clearinghouse. That lets you know that you did everything that you were supposed to do in order to get a clean claim to insurance. Now, there are a second set of eyes. When you get a validation and you get a warning, it gives you an opportunity to correct it. If you fail to correct it, it gets rejected, and so the claim just sits. So you want to make sure that you look at your 3 submission status. Next, Des. All right, let's do a wrap up and a summary. Some things that you're going to say, Pam, I know this. All right, so never include anything that's not documented in the clinical chart, which is Desiree's favorite. Use proper spelling and punctuation and grammar. Make it easy for the person that's reviewing your claim. Avoid handwritten narratives to make sure that everything is legible. And then omit irrelevant and unnecessary comments.
And then remember, you have 80 characters.
Yes.
Don't see anything else.
Got it. All right, last but not least, never use any aggressive language. I know that sometimes you get mad at insurance companies. Just go for a little walk around the practice and then come back. You want to make sure that you don't challenge the expertise of the consultant. And include clear diagnostic quality radiographs, and never send your originals, and make it easy for them. Go ahead and label it and put left and right. Clinical assistants are really good about this. And never send films that you are expecting them to return, because that won't happen. So make sure that you send things that you're not expecting for them to return. All right, Steve, you're up.
All right, so that was a lot of information on coding and changes and new things that you can do to up your game in that area. And we're going to throw in a little bonus here. So many times what we find in our work around the country, our team at Total Patient Service is all over the country every day. Our coaches help practices to implement the highest level of patient service and case acceptance skills in dentistry. And our whole mission at TOPS is to make dentistry the #1 patient service experience in healthcare. We see more of America than anybody else does in healthcare on a more regular basis. So we ought to be better at it than everybody else. So one of the mistakes that a lot of patients make is that they may think that if you're not in network with their insurance, that they cannot come to your practice, and that is not correct. So this is an additional tip, is to train your entire team on how to respond to this common patient question. do you take my insurance? And especially if the response is insurance with which you are not contracted, there's an opportunity here that might be missed that you can shift with the proper verbal skills. So, Pam, will you be my patient?
Happy to do it.
And in this scenario, Pam's going to be a patient that has insurance with an insurance company with which we are not in network. Listen carefully to my response.
Do you take my insurance?
Thank you so much for asking. Again, my name is Steve and yours is?
Pam?
Pam. Excellent. Thank you, Pam. And can you share with me with which company your insurance, do you have insurance?
MetLife.
MetLife. Fantastic. Well, good news, Pam. We have a lot of patients that have benefits with MetLife.
Oh.
And the good news is that we don't happen to be contracted with MetLife, but we do have a lot of patients that do come to us that have MetLife benefits. Would you like to know why those patients come to us?
Yes.
Well, we are an unrestricted provider, which means we can work with all types of insurance benefits, which means that when you come in, we'll do our best to explain what your benefits are. We will file those benefits for you so that you can do everything you can to maximize your savings. How does that sound?
Oh, it sounds great.
Which day of the week works best for you for your first visit? Would a Tuesday or a Thursday work better for you?
Thursdays.
Very good. So, and then we go for it. So let me dissect this real quick. Let's go back to the first slide. So what we recommend is you always ask which insurance company, and the first response, and this is true. How many of you, when I ask you this question, have patients with benefits that you're not contracted with or you're not in network? And most everybody does. So if it is true, then the first response is we have a lot of patients who have benefits with XYZ company. Okay. And again, it has to be true, but usually that is. And so what you can then say is we have a lot of patients who have benefits with XYZ. We don't happen to be contracted with XYZ or in network because we are an unrestricted provider. That's one of our favorite phrases. Unrestricted means we can work with almost all types of dental benefits. Would you, and this is the key question, would you like to know why our patients with your same benefits, why they choose our practice? That's the key question. They will always say yes. And then what you can say is what they tell us, what those patients tell us is they choose our practice because of our excellent clinical quality of care, our amazing patient service. And in addition to that, we'll file your claims for you and do everything we can to help you maximize your insurance savings. Which day of the week works best for you? So that won't always work, but it'll never work if you don't do it. So the key here would be train the entire team on how to respond to patients that have benefits that you may not be in network with, if that applies to you, so that you can maximize the opportunity. You don't have to be in network for them to choose your practice. And that's a common mistake that a lot of patients, misperception that patients make. Okay, we have a benefit for you. Let's go to the next slide. So if you want to grab your phone, one of the common requests we have with this particular topic is, wow, that was a lot of information. Can I have, the whole presentation, which is a lot. So what we've done is Des has done a beautiful job of summarizing all of the new codes, the revised codes, and the deleted codes in this hack sheet. So you are welcome to scan this QR code and download that hack sheet. And it's also in the chat section. You can copy and paste that quick URL into your browser, and you can pull it up, just fill out the information, you get the hack sheet. They'll give you a summary of what we've talked about today. In addition, since this is the end of our formal education part of our program, there is a lot that has to do with insurance coding and working cooperatively with your patients. So as you go along, when you have questions, our whole team at Total Patient Service specializes in coaching all aspects of the patient experience, including financial arrangements, coding, how you deal with insurance claims, and all things financial arrangements, as well as everything else. So as you have questions, there is contact information on this hack sheet, including a QR code on that hack sheet, that if you would like help training your team or have specific questions, our team is here to help. That's what we do with practices all over the country. We've got a very seasoned, experienced coaching team that'll help in every aspect of that process. So make sure you download the hack sheet. It's a great reference. And again, any questions, you can scan the code on that hack sheet for more information, for coaching help. Des does a lot of our virtual coaching where she works with teams remotely online to help them get things dialed in if there's support that would help you accomplish your goals. All right, Gary, we covered a lot really, really fast today.
Yes, you
And
did.
I know you have some additional things as well that will help teams maximize their productivity.
Yeah, absolutely. Thank you for a great presentation, Stephen, Pam, and Desiree. Folks, that concludes the CE portion of our presentation. And before we wrap up here, as Stephen mentioned, with all the billing and coding changes, disruptions to business, no matter what the situation is, having a great payment solution is integral to keeping the revenue flowing steadily, consistently in your practice. Some of those components include customizable messages, digital patient registration, text to pay, flexible payment plans, and card on file. Desiree, can you go to the next slide for me, please? And Bridge Payments has all of that. It's safe and secure, reduces the administrative burden, so no more, packing and stamping and mailing out envelopes. It decreases the accounts receivable, cuts costs with those paper bills, and enhances the patient payment experience. So, just moving on to the final housekeeping items here, folks. CE credits, as I mentioned earlier, will be emailed to you within 2 weeks of today, so be on the lookout for those. Next up, just a reminder that our next CE credit webinar is for HIPAA training. That link is in the chat, and we will also include it in the follow-up email here today. And last but not least, just a reminder, when this webinar ends, you will be prompted to complete a brief survey. Please take a few minutes, let us know how we did. Every response is closely reviewed and implemented so that we deliver the best training experience possible. Once again, Stephen, Pam, Desiree, thank you so much for running a great training. And to all in attendance, have a great rest of your day. Thanks for joining.
Thanks, everyone.
Take care.
Bye-bye.